Would you take the roll call, please, board members?
Yes. Gordon Mill,
Present.
Access. Oh, that's good for you. And the progress of our.
We can hear you.
$3 million for it.
Thank you.
Kenneth Craig,
Present.
Sue Carlton,
Present.
Sue Patterson,
Present.
Kevin Eccles,
Counter Fort.
Helen Claire Tingley. You're on mute.
Good morning, everyone.
Good morning.
Luke Charbonneau. Luke Charbonneau. Barfoot, Citizens of Rex. Nick Saunders. Nick Saunders. Gordon Peabody. Gordon Peabody. Gordon Peabody. Gordon Peabody.
Present.
Good to go. We have a quorum. Thank you very much. We have a guest with us this morning. I'll ask Dr. Ian Eric to introduce her.
Thank you, Mr. Chair. Dr. Graham is a senior resident in public health preventative medicine at McMaster University. She's doing rotation with us. And in the near future, she will be a specialist in public health preventative medicine. We hope to work with her in different capacity, whether it's across the province or virtually, or continue what public health has been doing. In the health unit, she's working on updating the policy, a project that started after the emergency, and she's doing a great job supporting us.
Excellent. Welcome, Dr. Graham.
Thank you.
And of course, Dr. Zayed is with us this morning as well. Welcome. Any amendments to the agenda required? I want to add an in-camera session. We have solicitors joining us at 10:30. The reason to go in camera was related to client solicitor privilege. Is that correct, Kaylee? Is that how to phrase that? Right? Okay. So we'll try to aim that for 10:30. And Dr. Era wishes to remove 11.2 from the camera session on your agenda because that item is maybe a little bit premature regarding negotiations. Okay, would someone care to move the amended agenda? Kevin and Sue Patterson, all those in favor? That is carried. Thank you very much. Is there any disclosure of pecuniary interest related to any item on today's agenda? Not seeing any. If one should arise during the course of the meeting, you can declare it at that time. We have educational notes that are related to advantages and disadvantages of regionalization. Dr. Air were you going to speak to that, or is that just there for our information?
I can speak to it, Mr. Chair, if you wish. And it's
Sure.
It's very timely, chosen timely with the announcement from the ministry about funding and voluntary amalgamations among health units. And it lends itself to regionalization, which is amalgamation or merger, depending on the terminology. There are certain advantages to it and disadvantages if it's done well and in consultation with the entities, the localities, the health units, and in this case, there are certain advantages related to resource sharing, increased capacity, enhanced expertise and standardization, and I can go in details for each one if there are questions. Economy of scale might not be very relevant to smaller amalgamation, especially in health units. We're not producing a product. We are delivering services. So there is definitely some economy of scale that I listed at the very end. Disadvantages, one of the major ones, loss of local control. And there are many examples of that could happen. Loss of accountability, probably not exactly loss, but reducing accountability. Anytime there is service that's evaluated by residents locally, they just can go to the local government and voice their concern. With regionalization, that becomes a bit more problematic, or there are barriers to it. There are bureaucratic complexities with big entities comparing to smaller health units. Communication challenges, it's another one. Cost allocation disputes, who's going to pay for what, and is it based on population or size or geography? And those would continue down the road, not just in the ironing of the way to amalgamation. Resistant to change, and that could be a factor to look at. So in general, there are advantages, disadvantages, if it's done very well, to maximize these advantages and mitigate the disadvantages. Open to questions as always, Mr. Chair.
Thank you, sir. Are there any questions from board? Ken?
Through you, Chair. Thank you, Dr. Ayer, for this report. I've read some information about this in the ministry as well. And is there an expectation that Grey Bruce Public Health will be under pressure to merge? Is that a board decision of any regard? Like, do we have a part in that decision making, or would we just be told?
Through you, Mr. Chair, the item on the agenda for full discussion of this subject, the question is excellent. It just lends itself to number 10, where the full discussion would be. This is just educational notes. And I can answer it shortly. Depends.
Okay, well,
It really
we
depends.
can wait till then.
You all right for that?
Oh, okay, absolutely.
Okay, sure. Any other questions regarding the information here? As Dr. mentioned, we will have a open discussion at item number 10. Okay, so that's good. Thank you, Dr. Ayer. Adoption of the minutes. We have 3 sets of minutes there. Kaylee, do we need a motion for each one, or as a group, is it okay? All right. Someone care to move adoption of those minutes? All 3, Sue Carlton, rather. Can you second it, Kevin? Any discussion on those minutes? Questions? Not seeing any. All those in favor? That is carried. Thank you very much. Correspondence and news releases.
So, Mr. Chair, correspondence that we have 4 items. The recommendation is to receive for each one of them. The first one is a letter from the Board of Health Thunder Bay to the Minister of Health, and it's emphasizing physical literacy for healthy, active children, and that's the title of the letter. And it's encouraging partners that are involved in education and local schools, sports, recreation organizations to emphasize on physical literacy, or calling on the government to call on these partners to increase the physical activity for children. The second one is a letter from Middlesex, London, and it's directed to the Premier, Ontario. It's calling on the funding formula to change back to pre-2019. And this communication came out before the announcement, so the announcement has taken care of that. And the province has already reversed that funding formula. The third item is a letter from Association of Local Public Health Agencies, ALPHA, to the Ministry of Health, to the Minister of Health. And it is acknowledging and thanking the provincial government for the announcement about funding and capacity for public health, which lends itself to the item number 10 that we'll be discussing in this agenda. The final one is a letter from the Board of Health for Sudbury District to the Premier of Ontario, and it's related to Bill 103, Smoke-Free Ontario Amendment Act. Vaping is not for kids, and it outlines the negative and the risks associated with vaping, whether related to lung damage, changes to the brain, dependence, addiction, difficulty learning, increased anxiety and stress, among others. It's calling on the government to amend the bill to reduce access and communication about smoking or vaping, rather. And my recommendation, Mr. Chair, is to receive all these documents.
Thank you, sir. Someone care to make a motion that we receive or approve the recommendation? Helen Claire, second? Ken, thank you. Any questions related to those? All those in favor? That is carried. Thank you very much. Media releases. Denise, welcome.
Thank you, Mr. Chair, and through you, there are 7 media releases on today's agenda. On September 5th, 3 media releases were issued, one to request the public's assistance regarding a dog bite incident in Saugeen Shores, another to advise the public about a heat alert issued by Environment and Climate Change Canada and to take precautions during the extreme heat, and a third to alert the public and partners about a cluster of drug poisonings which took place over a 4-day period. Grey Bruce Public Health also issued a media release August 28th to share that Grey Bruce Public Health will be marking International Overdose Awareness Day on August 31st. Members of our harm reduction team attended community gatherings in Owen Sound, Hanover, Port Elgin, and at Saugeen First Nation. On August 18th, Public Health issued a media release about a dog bite incident, this time in Chesley. And in early August, a media release was issued after a crow found deceased in Grey Bruce tested positive for West Nile virus, while another release informed the public of Public Health's plan to support families and students in ensuring children and youth in Grey Bruce are up to date on routine publicly funded vaccines. And that concludes the media releases on today's agenda.
Oh, it took you a long time to get through those, but that's good. Thanks, Denise. Are there any questions for Denise on those or any of those? Okay, thank you very much, Denise. So here we are, Medical Officer of Health update, Dr. Aaron.
Thank you, Mr. Chair. The first item is with Dr. Zayed about opioid situation in Grey Bruce.
Dr. Zayed.
Okay, Mr. Chair. Share my screen. So the update for the Board of Health in September about the opioid and unregulated drug toxicity, there was an escalated number of overdoses on September 2nd. Of 7 cases that were mainly in Owen Sound. This escalation also aligned with escalation all over the province. We have checked with the drug checking services in Toronto, the 5 local drug checking services, and there was no pointing to an abnormal or drug of notice, but it is just highly potent or combination of what is circulating. Immediate response from the outreach services in locally, the SOS to areas where overdose occurred, and Public Health issued an overdose alert. Discussion with drug checking service, as I mentioned, did not identify the drug of notice, which is abnormal drugs. It is essential to keep the services connected, more work on social system navigation. So we are, as a wraparound service, we are developing or strengthening more the services that we are working on, and including the treatment and the social navigation in the system, which is important as a holistic approach. Outreach, it's good also to know that outreach project in Bruce County that Public Health gladly supports. It's a sort of also integrated support service outreach. They are proposing that to innovative application and application for innovation, and hopefully this will be accepted and it will be similar to SOS in Grey County. So it's really because this service has been really proven to be very supportive and helpful on the ground, and it's not only the harm reduction, but it also provides a holistic approach for wraparound services. So we hope that this will see the light soon. On the local level as well, the drug and alcohol strategy, we have a restructuring of the drug and alcohol strategy to align with the community needs and the changing of landscape of drugs. So we are meeting to in the near future to work on the strategic planning for the local drug and alcohol strategy. In terms of harm reduction program here in the health unit, we are restructuring the program so that it doesn't focus only on harm reduction and providing naloxone, but also to work collaboratively with the health promotion and foundational standard on a holistic approach. And we wanted to finish or complete the locally driven collaborative project on prevention. And we are gladly completed the project. And with that, we have really good takeaway from that project that we want to implement at the local level. One of the things, for example, is the school setting programs that proved to be successful for youth to improve resilience. So we are really in the near future focusing on that. The other part of collaboration is collaboration between public health, the outreach services, namely the EMS, and the police services. So on September 20, we will have a good discussion for a whole day. I will attend with the paramedics and with the police. So we have a kind of dialogue and knowing the barriers also from the police perspective. So this is part of our collaboration. So the police is a core member in the drug and alcohol strategy, but it is great that they have invited us also to have this kind of conversation. This is the locally driven project. You are the first one to see the cover. So that's the project. It came to conclusion, and I will be glad to present a presentation on that project and provide the report as well in our next meeting. Thank you.
Thank you, Dr. Zayed. Are there any questions for Dr. Zayed regarding her report? Yeah.
Through you, Chair. Thanks, Dr. Zayed, for keeping us informed like that. And if I may, I'd like to touch a little bit on the drug strategy restructuring. Is this the phoenix rising from the ashes again, like this drug strategy coordinator had chosen to step aside, predominantly because of funding issues? Is that this drug strategy reorganized starting again? Is that what you're telling us here?
Well, I was not really satisfied about that performance because it was part of the top, more like a very big chunk of time was about searching for funding for coordinator position. So there are lots of things that we need to reorganize. One of the things that public health will take a role in the coordination so that it will be an in-kind integrated role for working with the chair of the drug and alcohol strategy. The other thing is that we will work on the 4 pillars approach, but in a more integrated way, not specifically the 4 pillars, but integrating holistic approach rather than focusing only on the harm reduction and trying to have all the members collaborate in the strategic planning. So we will have a workshop for the strategic planning so that we can have indicators, goals, and outcomes.
So if I may just confirm, I think what I heard you say was, yes, this is the new birth of the old drug and drug reduction strategy.
Yes.
Like what you just described now is the restart and the different way that Grey Bruce Public Health is choosing to be integrated into that.
Yeah.
Right, but it's the same thing, different leadership, different focus for
It's the
So-
same leadership, but different roles for other core members.
Dr. Eric?
Thank you, Mr. Chair. Just, I echo what Dr. Zaid mentioned, but I think there are two discussions happening here. We have been working with the group, and it's a group of all partners in Grey Bruce that involved in the strategy. So it's not health unit committee. And we continue to collaborate and evolve. This group has evolved like it should. The crisis continues, the opiate crisis continues, and there are more interventions that can be implemented, or more funding that can come to certain things, or whatever factor that requires development has occurred. We continue to work with it. So it's evolving. It's not related to a resignation of one individual or not. This happened in complete separation of the involvement of the group. We cannot talk about individuals, especially from other health units, regardless of the reason of the stepping down. The plan of involvement and changes that Dr. Zaid has been presenting on have been planned and executed over the past 6-7 months and more. So not related to the resignation of the individual in that organization or in a partner organization.
Thank you, Dr. Era, for clarifying this point, because even with the previous coordinator in the role, we started this conversation before that. But we want this committee because it's a community committee, and it's important to continue as a community committee and a collaboration. So we step up to get some in-kind roles to help, but the chair, the other core members are the same.
Good. Helen Claire?
Thank you, Mr. Chair. Through you, my understanding of what I heard from Dr. Zayed is that going forward, there's going to be a more holistic approach to the treatment of addiction, not simply focusing, as we have seen so much in the past, on the harm reduction aspect, that it's going to be balanced more with harm reduction continuing to be one aspect, but not the sole aspect. Could I just have a confirmation that that's what is happening? Because that's what I understood. Thank you.
Through you, Mr. Chair, that's clear, Helen Claire, what you understood. It is just an important, like we didn't have much focus on prevention. So we want to have this prevention, especially for youth, to focus on improving resilience. So one part is really focus on harm reduction and treatment, which we have through the outreach services right now, and evolving that with a more of even that part of harm reduction and the treatment, taking a holistic approach, having social navigation and helping people for employment and housing and all this wraparound services. But we want also to have this holistic approach for the prevention, so that we focus on resilience, and there are really successful programs that we want to adopt in our schools as well, specifically.
That's fantastic news. Thank you.
Thank you, Dr. Zaid. Gavin, did you have a question?
Yeah, you said something about the maximum. And police have it. Is it available for every person to carry a maximum kit?
Yes, it is available for everyone, and there is a new guidelines called Take Home Naloxone guidance, because there was no evidence-based publications about it, but Canadian Medical Association has found in Canadian Medical Association Journal, there is a new publications now, and I shared it yesterday. It's just very new with our Community Advisory Committee on Public Health Issues, which include all the members, including police and EMS. But this is something that we, since the escalation in January, we are focusing on that everyone can carry naloxone, and not only that, the intranasal and the oral one. And so there is a three things naloxone intranasal and oral and the other, the intramuscular and the respiratory health support. So we will be implementing that and focus on implementing that, because just an alert every now and then is good, of course, to put a public health alert, but we always want to have more focal work on saving lives.
I guess further to that, especially with the injectable, a reaction or something in today's litigious society. I'm carrying it. Somebody on the street sees it down, I give them the Naloxone. My understanding is, to alleviate any public concern about carrying that and giving it, it's under the Good Samaritan Act.
Yeah.
that we as lay doctors out there certainly wouldn't be anything liable or anything of that nature, because I have, in conversations, individuals, I'm not, well, yeah, I guess it would be an individual choice, but.
Yeah, but it
They
is,
would
yeah,
have-
under the Good Samaritan.
Okay, any other questions? Sue?
Thank you, Mr. Chair. Just a further question to that. So I remember a presentation made at Inner Township Fire Department about 3 years ago, and it was about the naloxone. And one of the things was a caution in how you keep it. So somebody having it in a vehicle in the heat of summer or the cold of winter would reduce the efficacy of that. Is that correct? That it can't take too hot or too cold?
Extreme of temperature, of course, we need to be careful about that, but the most important thing is the expiry date as well. But the problem that we face now is the combination of fentanyl with other benzodiazepine, so combination with other drugs, and there is also another drug that was in drug checking service, phenacetin, which was an analgesic painkiller that was prohibited since the 70s. So it's back in this combination. So all this also affects the response to naloxone. That's why we want to have respiratory resuscitation first.
Thank you.
Okay, Ken?
Through you, Chair. So is it, am I hearing the suggestion that our Board of Health should be more proactive in directing funds towards providing kits to the general public? Like, do we have a policy or a program being thought about that we would implement a more widespread distribution of kits? Like, it's nice to understand how they work, but that doesn't mean anything if we don't do anything about it. So I'm just wondering if, through you, if staff has started to contemplate anything like that within the budgetary process.
Good question. I have no idea. Dr. Zayed?
Mr. Chair, we have a budget for naloxone. For now, we don't have problems with the harm reduction program, but with the new guidance coming, we will discuss that and we will see if we will need a budget. For sure we will provide that.
Okay, thank you.
Okay. Motion to receive Dr. Zayed's report. Ken, Sue, Carl? All in favor? That is carried. And I have to apologize, I missed to ask for a motion to receive Denny's report or his media releases. Yeah. And correspondence.
No,
Sue?
you did correspondence.
Yes, I did. But I missed the media release. So, Sue, would you make that motion? Seconder? Helen Claire? All in favor? That is carried. Thank you very much. I see our guests for closed session are here, so I'd ask for a motion to go into closed session to discuss client solicitor privilege. Sue Carl, seconded by Ken. All those in favor? That is carried. And I would ask Dr. Graham and Dr. Ian to please excuse yourself from this
for the board knowledge to receive this information. The program itself is based on the Child Visual Health and Vision Screening Protocol that was introduced to public health in 2018. We had a pilot before the pandemic, and since the emergency was declared over, we have here key point summaries of this program. 88% of senior kindergarten students from 47 public elementary schools from the three boards, the Catholic, Blue Water, and the French, they were screened for vision during last year. And the screening takes place in partnership with the Lions Club International. The standards and the protocol from the ministry require the health unit to partner with local community partners that do vision screening. So I identified Lions Club as an active partner, and they have been very helpful in volunteering to do the screening. 40% of the students had vision concerns on the screening. That doesn't mean that all of them actually have vision issues, rather just the screening picks them up. And down the road, they will be given recommendation to follow up with an optometrist. Even the people who tested negative, they will also be given the probabilities of the test negative being false negative. And the vision screening itself brings to the attention of the parents and the schools the need to do testing, and the testing is covered under OHIP for that age group. So the results were 27% of the students had visited optometrists since the vision screening. Have said the screening made them more likely to be looked to book a visit. Of the students who visited an optometrist, 22 out of the entire group had vision concerns identified, and 14 needed glasses. That's 14 out of the 27 who did the visits. For those who have not visited optometrists since the screening, most have had the appointment booked or plan to be booked according to the surveys. So in general, the program is a new program, and the goal of it is to increase the awareness of the public about the need for such testing at early age before school starts. And all in all, we do have the program component in place, and the last year results are encouraging that there is a response and good coordination, collaboration with the partners. It's covered under the financially it's covered under the mandatory program, and the staff that works in it have been, as I mentioned, working with the volunteers from the Lions Club. So all in all, it's a summary for this program. Chip.
Thanks, sir. Any questions for Dr. Ayer regarding that report? Motion to accept. Oh, Kevin, you have a question or?
Just a comment that being a president of one of those A9 Lions clubs that the Lions been doing for a number of years, and we're certainly there's a great concern of this program falling off, and the Lions Club will do whatever we can to ensure it retains and stays successful. And it was a pleasure, I can say, on behalf of the members that did work on that. One of the ladies has probably been at it for 25 years, give or take, and she said her eyes are good. Getting in and out of the class, my knees aren't as good anymore, but my eyes are still good, and I'll keep doing it. So yeah, excellent. Great work, great partnership. Thank you. Excellent. I will move.
Thank you. Second. Ken? All those in favor? That's carried. Thank you. The next report is regarding strategic plan for IPSA. Here,
It's the presentation from one of the managers.
Okay.
He's joining us.
there I see her on the screen. If you want to introduce her, Dr.
Certainly, Mayori's new manager with us. She's been with us for 6 months now. She has been running the vaccine program. She comes from another health unit where she did work in a vaccine program, and she's bringing a wealth of knowledge and energy to the program itself.
Excellent, welcome, and the floor is yours.
Thank you for the introduction, Dr. Era. I'm just going to share some slides with everyone here for my presentation. Let's see if I can just get them up. There we go. Is everybody able to see the slide deck?
Yeah. Looks
Perfect.
good.
Thank you. Okay, so I'll get
And then
started. This presentation today is just to discuss the strategic plan for ISPA. So I'll just go on to our next slide here. The outline for the presentation is that we'll talk about the background of ISPA first, and then our implementation plan, and then our communication strategy as well. So moving on to the background. So what is ISPA? ISPA is the Immunization of Schools Pupils Act. It applies to all students attending primary and secondary schools. And under this act, students are required to provide proof of immunizations against 9 infectious diseases, unless they have a medical or non-medical exemption, of course. So in terms of the background of impact from the COVID pandemic, suspensions didn't take place during the COVID-19 pandemic, and for a portion of the pandemic, school immunization clinics were also put on hold. And this was the case all over Ontario. So it was something that every health unit had to do due to the change in priorities. Now, the situation with ISPA is that it's designed to protect the community, and we're able to implement it and protect the community with the help of our schools and our school officials. With the ISPA suspension prevention plan, which is a lot of the work that we did this summer, we mailed out letters, we held catch-up clinics in a variety of areas for students who were not up to date. We implemented a strong communication campaign, worked with primary care to get student records from them and get students immunized, as well as making phone calls to parents who it was difficult for them to receive the letter, or maybe they just didn't get a chance to respond to the letter. And we're still continuing to make calls to those parents. The challenge with ISPA this fall is that now, due to COVID-19, another vaccine is added to the public health portfolio. And the number of students who are not up to date at this point is a little over 4,000 out of a little over 23,000 students. So when you look at the numbers, most students are up to date. But since we've had great coverage rates, the 4,000 number is still significant for us here compared to a pre-COVID year. And this is something that all public health units in Ontario are struggling with due to the impacts of COVID-19. So I'll just move on to our next slide here. Our ISPA operation plan. So how we operationalized our strategic direction. So first we looked at strategies that were successful in the past and reused those strategies. And then we implemented new strategies as well. So when we were looking at new strategies, we looked at supporting research and the literature, and also collaborated with other health units to see what had worked for them in the past, or what strategies they're using currently that are working well for them. And then the considerations that we took. So we considered the impact that the trust, the community has on public health, as well as the safety of the community, the legislation of ISPA that the health unit has to implement, and our capacity to carry it out whenever we think of implementing an intervention. Next, we will go on to our documents. So any documents or communication that was put out to the public was reviewed by the manager of the vaccine preventable disease team. So that would be me, the communications team, my senior manager, as well as the public health physician consultant. So the content was formed by myself and the VPD staff, and then the wording and the tone was developed by our communications team, as that is their area of expertise. So next we'll just move on to some communication considerations. So one of the things we considered definitely was being transparent about suspensions. We're planning to do suspensions, and we needed to let the parents know that this is something that was coming up. People have not heard the word suspensions for a long time, and it might be alarming to some, but this is what the legislation requires, and kind of the term that's used in there. So if we replace that term with something else, then we're not being transparent with the public, and the communication might not be as clear. We also considered reintroducing the idea of suspensions after COVID-19. We understand that reintroduction of suspensions should be done carefully at this time, and to make sure that each document, going to the public was reviewed by multiple team members, and as demonstrated in the previous slide, people who were experts at specific things, reviewed the document for those things. For example, the communications team really looked at the tone and the wording of our communication. When it came to language usage, non-threatening terms such as may be suspended or can be suspended were used in our suspension prevention communication. This was done to let the parents know that suspensions are a possibility, to keep that transparency, meanwhile maintaining a friendly tone. For strategic communication, we provided communication in a way that was easiest for clients to understand or community members to access. So I'll just move on to our next slide here. So just some examples of our communication here. So we distributed letters directly to parents, and then we also distributed letters to parents through the school as well. And so those letters were really focused on getting the information that the parents needed to them. We also did media releases where the communication was targeted towards the general community as well as parents, along with our social media content, again, was for the community and parents specifically, as well as our radio advertisements. We also sent out memos and newsletters to primary care providers to work with them and try to get students up to date. These are also the media releases that we sent out in our effort to get students up to date, as well as suspension prevention work. So we sent out a media release about in-school clinics resuming, and then another one in June about holding catch-up clinics for students who are not up to date, and then another one in August to continue to promote those catch-up clinics for students and support them in getting up to date. I will just show in our next slide here some of the examples of our communication. So these are just some of the examples of the communication that we sent out. We did send out letters to parents, as I mentioned, and in those letters, we provided a variety of resources where clients can book appointments with us, and parents are made aware of the legislation, as well as provided a variety of ways for them to submit records to public health as well. This is some of our social media content that we put out. And so it shows some of the dates that we held our clinics. We posted this on Instagram. Also, we posted this poster here that talks about preventing suspensions and really promoting people to submit their records through ICON. So we developed a QR code that was put on the poster. We also used the same QR code on the letters to make it easier for the parents to submit records right away to us. I'll just move on to our next steps going forward. So going forward, we plan to do grade 7 and 8 school clinics. And so there we plan to immunize our grade 7 students, catch up the grade 8 students who maybe missed some vaccines. We also plan to suspend JK to grade 8 students this fall, and we plan to provide catch-up clinics for those students during the suspension period. Community clinics in Owen Sound and Walkerton will continue throughout the fall for anybody who wants to get vaccines done and they're not able to go to their family doctor, or maybe they don't have one. So we're available to that population as well. And then we'll also be having some flu and COVID-19 vaccinations. So we're working with the community partners to provide immunization clinics and protect the community this fall against our respiratory illnesses. So that's it for my presentation. Thank you very much for listening. Does anybody have any questions?
Thank you, Mary. Are there any questions for Mary regarding her report? Okay, not seeing any questions. Thank you very much, Mary, for the report. Quite comprehensive and interesting. Thank you.
Thank you.
Okay, well, we need a motion to receive her report. Someone, Helen Claire, second, or moved by Helen Claire, seconded by Sue Carlton. All in favor? That is carried. Thank you very much. Corporate Services Financial Report, Dr. Ayer, or we got Kim coming to you take us through the financial report, please.
Absolutely. For you, Mr. Chair, this is the July 2023 financial update. We received our 2023 funding package in late August. The ministry approved a 1% increase to our base funding. And that's what they approved for all public health units in Ontario. They also announced that they will provide growth funding of 1% to our base programs for the next 3 years to facilitate budget planning for the health units. They are also going to restore provincial-based funding to the levels provided under the 2020 cost-shared ratio. So that's when they announced that they were going to move from a 75-25 split to a 70-30 split, which would result in the counties having to pick up an additional 5%. So they are reverting back from that, back to the 75-25% ratio. We also received one-time funding for a PHI practicum, which we hired already for the summer. So we've had that student with us and they've done their practicum. We received funds for a new vaccine fridge, so we're actively working to get that in-house before March 31st of next year. And we received funding to cover the cost of one of the new dental chairs for the Walkerton Dental Clinic that we're going to construct. For our financials at the end of July, we were sitting in a deficit of $91,000. Our mandatory programs and COVID expenses were currently covered with our base funding. It was the seniors dental program that's running the deficit. So it's about $180,000 in a deficit right now. So the ministry has said that there'll be opportunities through our third quarter reporting to ask for additional base funding for that program. There's a lot of health units experiencing pressure in that program, so we're not alone in this. And the ministry knows that they've expanded eligibility for the program, but they haven't necessarily increased the funding associated with it. So they are recognizing that there's pressures there. So we'll be applying for that funding as part of our Q3. And at the fundings and revenues, so I've updated our year-to-date funding from the ministry cost share line to reflect the 1% increase approved by the ministry. So we'll see that line will be under budget for the remainder of the year because we did ask in budget for a 2.5%, but they've only approved the 1%. So we'll see that shortfall for the remainder of the year. The salaries and benefits are under budget by $450,000. So we budgeted for all of our permanent and contract staff to be with us for the full year. But some people have found permanent jobs or we've had some leaves. So that's resulted in gapping in some of those wage lines. Our building occupancy costs are in line with our budget. And our operating expenses are, they're in line as well. It's mostly the higher dentist and dentist fee line, which is associated with the seniors dental. That's causing the variance in the operating expenses. And lastly, for the Walkerton Dental Clinic, so the construction RFT for the Walkerton Dental Clinic is posted. They did the walkthroughs of the site with the contractors last Friday. The bidding is supposed to close late September, so I think it's next week that the bid should be in, and then we'll do the evaluation and scoring process to secure hopefully a contractor for the site.
Very good. Thank you, Kim. Any questions? Ken?
Through you, Chair, and through you, Kim, perhaps ending up in Dr. Ayer's chair. I had highlighted the dental fees to just to get a better understanding. So the dental clinic in Walkerton hasn't started operating yet, or is it expanding? Can you help me on that?
Yeah, through you, Chair. So we have a pop-up clinic site in Walkerton right now, so we do have a space, but this will be a larger, more permanent location that we have that will be, I think, 1 to 2 days a week running clinics out of. So it'll just be expanding on what we currently have in that area.
Yeah. So the the significant investment in it, and I agree with it. I have some dental hygienist friends, and like they can never stop talking about how important healthy teeth are. But I'm wondering if through yourself, Mr. Chair, Dr. Ayer, you could expand on just a little bit of the connection between good teeth and good health. What extent do we provide the program to at this point? And are there plans for expansion? If it's that important for people, then are we going to grow that program? Could you just broad, high level conversation, if you would, Dr. Ayer, please?
Certainly, through you, Mr. Chair. Oral health, which includes teeth or dental health, and includes anything else related to the oral cavity. It includes screening for cancer or other things. It's way more than just the dental aspect of it. Is directly related to good health on many fronts, whether it's the ability to consume food, have good nutrition, good digestion, or as I mentioned, the screening for certain diseases. And there's plenty of information on our website for the public to look at that. The program itself has been introduced a number of years ago for senior dental care specifically, and it's under the standards requirement number 5. The Board of Health shall provide Ontario Senior Dental Care Program. Usually the standards or the Health Promotion Protection Act would use the language shall ensure the provision, which means we can look at who's in the community doing this and mobilize them to ensure that there is coverage in all grade groups, and if there are areas that are lacking service, we step in and provide it ourselves. But the language in the standards is actually we shall provide it ourselves. So that this program is provincial and it's newer program, and it's we deliver that aspect of vetting, taking care of applications of the seniors, ensuring they were processed in time, and ensure the delivery of service in certain occasions. So all in all, it's a program that started a couple of years ago. We have seen quite the demand on it, and after the emergency was declared over and we tailored our efforts. During the emergency, we still worked on it, but not full capacity. We have had a waiting list, and we have been executing this waiting list to the best of our ability. Should be done soon, catch up. So the plans for reevaluation of this program will happen automatically like we do with our programs. And if there is any need to expand, will be based on the health need in the community. Is the list of people who require this program is known, and there are no applicants. We have the capacity to do this, to deliver the services. And if what we have as infrastructure is taking care of that demand, that will be the decision to continue what we have. If there is a challenge with providing the demand will up the capacity. If there is a challenge with access and equity, rural areas versus closer to urban areas within Grey Bruce, again, that will be a criteria to look at what we do. And there is nothing pre-baked whenever we're looking at health programs. It is responsive to the health need of the community. Is it met or not? And how we can provide it easier.
Okay, good. Any other questions on the financials? Kevin?
Just, great stuff. The expenses are certainly down, but the revenue, it's the one-time funding. Did I catch it that in the third quarter, we're going to get caught up on some of that one-time funding? It's just on timing.
Yeah, for you, Mr. Chair. So the one-time funding, so right now in that line is the school focused nurses and the IPAC hub. What's not in that line is the COVID extraordinary funding for 2023. So the ministry isn't pre-approving that for 2023. So before, when you got your funding announcement, they would, if you'd ask for $1 million, you'd get your letter saying you could approve for $1 million, and they would start cash flowing it. They want health units to report on what their actual COVID costs are in Q3. And then depending on what's reported there, they will approve you based on what you've actually spent, because they found recoveries for some health units last year were so substantial, like millions of dollars, that they cash flowed up front and then just had to recover. That process didn't work. So that's what they're doing for 2023. So it'll be in the fall after our Q3, where we kind of indicate how much COVID funding we need to cover our costs in this year, that we would get approval and then the cash flow for it.
So we're looking, you're hopeful that it will balance out on that timing aspect of by the end of the year.
Yeah, so I think we'll have some of our, so you have to exhaust your mandatory base funding first before you're eligible for the COVID extraordinary. So we're in a good position with our base funding. And then if we get to the point where that's fully exhausted and we're in a deficit, then we can claim that deficit to cover the COVID costs that are mandatory separate. So yeah, we're sitting in a good position as of the end of July.
Thank you. Ben, through you, Chair, do you have a line of credit at the financial institution? Like, do we get behind sometime in cash flow? I don't remember passing a agreement with a bank of some sort or other. How does that work for the board of health there? Okay.
Yeah, through you, Mr. Chair. So yes, we do have a line of credit. We've been fortunate that we've never gotten into a cash flow situation where we've had to use it. So the province has adequately cash flowed us even through the peak of the pandemic for us to cover our own risks.
Dr.
Mr. Chair, if I may elaborate and add on what Kim mentioned, she's humble in her statement that we're fortunate. We're well served by good planning from finance. Her work has been exceptional. We presented to the two counties last year or the year before, or both years, on the exceptional ability for the health unit to actually respond to the pandemic without asking for any increase from the counties for the past 5 years. It was highlighted in 2 media releases. And again, that's thanks to the senior management team and the finance team.
Good point. Good point. And the counties, thank you. Any other questions? Financial. Helen Claire?
Thanks. I just wanted to comment that it's good news about the restoration of the provincial base funding and the resulting $1 million savings to Grey and Bruce counties. I recognize that we rely on that's how the health unit is funded through the counties. So even though there's lots to be concerned about going forward, and I know Dr. Ara is going to speak to some of that, I just wanted to make sure that we didn't lose these two pieces of good news that are there today for us.
Thank you. Any other questions? Okay, could I have a motion to receive the financial reports? Sue Patterson and Helen Claire. All those in favor? That is carried. Thank you very much, Kim. Appreciate your time. Okay, so our last order of business today is other business, and it's the Minister of Health's recent public health funding and capacity announcement. Dr. Eric.
Thank you, Mr. Chair. So this is the main item on our agenda, and I think it's going to keep us busy for the coming months and could be a couple of years. So the Minister of Health had an announcement, and like Helen Claire highlighted in the last item, there are positives in it. There is certainty of 1% increase. Public health has been frozen for a period of time. There are 3 years of stability that we know that we're going to get this 1%. And there is a reversal of the mitigation funding. So for that, I can see how Alpha positioned their letter from correspondence to item number 3 to thank the ministry. Nevertheless, there is a number of concerns, and I have as MOH, and I know a number of other MOHs have about the announcement. In general, it brings back the same shadow of amalgamations or mergers, the M word in public health. People don't say it, but it is a merger. That happened over the years with different governments, whether from the right or the left. So it's not a new subject, but now I see a bit more concern comparing to the 2019. In 2019, there was a vision that was shared about the number of amalgamations that will happen, and the full product was shared. Now we have a staged approach where we know the first step is 1% increase for 3 years, which is in light of inflation and in light of collective agreement that there already been signed, is actually a funding freeze. 1% is not going to deliver what the agreements have been or the inflation has been or it could be. So that is a concern. We don't know what the final product is. We were told that voluntary amalgamations are welcomed and the blessing will come from the ministry if 2 health units wanted to stroll down the aisle. But after 3 years, smaller health units that have not volunteered funding will be voluntold. They will be told to volunteer. So again, what does that mean and how does it work? There is in the communication, there's need to focus on core public health functions, and it could be positive, or it is positive for one way, that with the budget freeze, we're not going to be able to deliver all our services. So this is a way out to say we do not meet all the indicators on these fronts. But at the same time, what is core functions? The public health works is in a bigger approach to the whole community. And the core functions, when they're decided, and there will be non-core functions that will be uploaded to the ministry or given to different providers. And that's quite the change. And this adds to that, the standards will be reviewed next year, 2024. And the result of that review will most likely decide what core function is and what amalgamations should be. So in 2019, everybody who has been around the table here would remember there was quite the concern. The Board of Health will dissolve and there's going to be an amalgamation with a neighboring health unit, and we can work through this. Now we don't even know where the end result is. Is it going to be our board dissolves and amalgamates with another board? Is it going to be a smaller size similar to us, same geography, demography, or it's a bigger region? Is it going to be the same functions? Is it going to be a different entity like Ontario Health or other entity that would take the functions from public health, or are we reporting to? So there are many uncertainties about it. The final vision is not here, which is causes quite a concern for me. The other layer of concern comes hand in hand with this one, which is in the announcement, there was a promise to municipalities, if there is extra funding, if there is a shortfall in the budget from the health units, it will not be picked up by municipalities. That's a promise cannot happen unless the Health Protection Promotion Act is opened and changed. And when you open the act, you can have all the possibilities that could be concerning to a different degree. And I'm painting the picture of where the concern is. I'm sure with every concern, there is opportunity to actually build something stronger than what we have. And so long that it's done in consultation with the boards of health, the municipalities, all the involved partners in the equation. So I'll stop there, Mr. Chair, and I would really appreciate the input from the board on this.
Okay, thank you, Dr. Eric. Questions, comments, thoughts? Sue?
So I do have just some comments because I was able to attend the minister's funding announcement through ALPHA, which is the Association of Local Public Health Agencies. That was on August 31st. There were 78 participants there. So a lot of interest. Dr. Kieran Moran, our Chief Medical Officer of Health for Ontario, highlighted the announcements, and I just have some notes, and probably Helen Claire has some too, just about the merger. So the question was asked, what happens if health units do not merge? And that's where the word voluntold was mentioned by Dr. Moore, saying, health units will be voluntold if they do not voluntarily merge. And he mentioned the number 10, which we've heard quite a few times over the years, that the province would like to see 10 health units. And I believe we have 34 right now. So he also commented that any health unit that serves a population of less than 500,000 should be merging. And it should be a geographic neighbor, but they would be open to discussing geography of a further health unit. Now, how that would work, I don't know, but he said they would be open to discussions. So, and health units can take on large health units can take on smaller health units, supporting in a regional manner with contracts. So I think that was just a seed that was being planted, that merger is in the works. And Helen Claire, if you want to add to any of my notes, please do so. You're muted.
You're muted, Helen Claire. Sorry.
Through you, Mr. Chair, I did watch my colleague amongst those 78 people frantically scribbling notes down. I thought, yay, Sue. I did ask questions of Dr. Moore because the 500,000, there are some exemptions. So, for example, the City of Toronto or Toronto's health unit, which is not an independent health unit as ours ostensibly is, but that would not be expected because it's over the threshold of 500,000 to partner with anyone else. So I attempted to raise with Dr. Moore that the 500,000 was not taking into consideration rural communities who, although they don't have 500,000, they have to service large areas. And he acknowledged that, but didn't really answer my concern. So I went further and said, so what would I tell my colleagues around the board table about why it, like in my rural community where I serve, about why this would be a good idea? Because it seems to me that the local we will not be in the same position to service local needs in such a case if we are, say, teamed with London, for example. And Dr. Moore's response was to the effect that because we've now learned how to be virtual, and because our jobs as board members is really governance, that it wasn't going to make a difference to services. So the in other words, the dental chair and the vision program and so on would still be there. So I'm just passing that on. That's we have a lot to chomp on here. It seems to me, and I did have a follow-up conversation with Dr. Ara where I asked some pointed questions. We're getting to the end of this meeting, so I don't want to go on a lot about it, but it seems to me that if you add a layer, if we are, say, if we get together with London, what would the board composition be? The board composition here around this table is legislated in our regulations, right? It is municipal councillors through the county and then provincial appointees. If we team with somebody else, what would that makeup look like? And would the makeup of the board be commensurate with the population. So in other words, if we were to team up with London, which has that sizable population, would they have more board members that represent the London area? And how would that impact the needs of our local community for funding decisions? So that's something I think that we need to talk about as a board, the potential. If they're changing the composition of the board, that would require opening up that legislation. So that doesn't seem like it's a fast thing in particular. So there's a lot. I'm not going to pretend that I did try to ask what's in it for us, what would be good for us. I wasn't successful in getting something that I can bring back to you, but I think it is something we as a board need to discuss, particularly with the threat of being voluntold. Thank you.
Thank you, Helen Claire, and thank you, Sue, for your comments. There is indeed a lot to think about there. It sort of has echoes of amalgamation from years ago, that's for sure. You either do it or you're going to get told. Well, some didn't do it and they weren't told, but here we are. Dan.
Thank you through you, Chair. So as a board member, my interest is in to hear the staff's recommendation. So I'm interested, Dr. Era, if you could give me a very broad overview of either the series of reports, what we need to hear about options, pros and cons. We need to hear about timing. Do you have any sense at this point about what some of the information you will be bringing to us so that we can, engage as best we can with nothing personal to Ms. Tainton, but I don't want to merge with London. Very nice people. My daughter works there. It's a great spot, but no, just broadly, it's Grey Bruce here in Perth. There we go. So,
Wellington Simcoe.
good. Anyway, so
I'm a lot closer to them than I am Perth and Huron.
anyway, so there's geographical areas that make sense. So I'm wondering if you have a sense yet of the information you will be able to provide to us or the timing of those reports. Can you speak to that yet, or is it too early in the process?
For you, Mr. Chair, what we know so far has a lot of uncertainty built in it. And if the plan is to do it over 3 years, it's understandable. We will be receiving this information as we go. We will be receiving the information from the ministry directly through the chief MOH to the COMO, the Council of Medical Officer of Health, which I will share immediately as I receive. There will be communication with among MOHs that I can share as well. The board will receive information through Alpha, for example, the meeting with the chief MOH. I don't believe MOHs were invited to. I didn't see my invitation. So again, there are different ways to skin a cat.
Yeah.
So there is no right or wrong how it's going to be done. But as a board, we need to be proactive. In 2019, we were the first health unit, to my knowledge, to go to the ministry and say, you want 10% budget cut roughly, we can do this. And we can build a new vision. And we can lead in what the new future is going to be instead of being told after 3 years what it is going to be. It is, my recommendation would be to be that proactive board and move as fast and robust as we can to respond to the local needs. And I don't believe HC had recommended to amalgamate with London. She gave it as an example. So there are ways to look at what the local need is, and usually the further from the local need, the centralization, the first application notes that we looked at, the first disadvantage would be loss of local control. I can give the example, and you can repeat it many times during a pandemic, where if the health unit needs to respond to an outbreak in one of the towns in Grey Bruce, and our response would be deploying staff, would be getting information from the mayors, getting information from the partners, communicating with the media release. All these things can need to happen within minutes, not within hours. So if we're connecting to London to get an approval on a media release, you can just appreciate how many hours is gonna go before we get the okay on what we're gonna put in the media release or not. There is no benefit for local public health in going in bigger entities. I do believe this, and that's was one of the core reasons why I wanted to work in smaller health unit or mid-sized health unit where you're connected with the community. So again, it is the proactivity of the board to move with a vision of its own. And I'll be more than happy to do all these things to, as an advisor to the board, to provide it, but at the same time, it's the board that's moving.
Thank you. Ellen Claire?
Yes, Mr. Chair, thank you. Just to add that I would be remiss if I didn't report that Dr. Moore did suggest that that they are open to creative suggestions. So sharing of services, I think was given as an example by another board member as a potential. So we could spend some time and be creative. If this is something that has to happen, we could look at how would it best serve Grey Bruce? Who would we want to partner with to reach that 500,000 threshold? Not just in terms of proximity, but in terms of similar values, where we might get traction on the things that are important to us as small communities. So Guelph is a small community, for example. And the question was also raised by another board member about how many, is there a limit to the numbers of partnerships you could have? And it seemed that there was not, but we as a board might want to consider that the smaller number, if we could hit that merger with just one other partner, that might give us, continue to give us more control over our local public health than if we try to go with many. So just offer that and stop now. Thank you.
Thank you, Ellen Claire. Well, I suggested lots of thoughts, lots of things to consider, and probably a bigger agenda item than just today. So maybe in the future, Dr. Aaron, you could maybe reintroduce some of the information that was brought forward in 19, because we do have some new board members that they could look at and see where the board was at in that process. And we could kind of start there maybe and see where that takes us. So with that said, thank you very much, Dr. Aaron. Thank you. Thank you, Kim. Thank you all, staff. I believe that concludes our agenda. Someone will move adjourned. Dr. Aaron, sorry.
The next meeting is September 22nd. I wonder if the board want to decide to.
Right. So we do have our regular time is September 22nd. I'm not sure we need that meeting because obviously it's only a week and a half away from today. What's the consensus of the board, or what are the thoughts of the board members? Do you want to meet on the 22nd, or do you want to wait till October for our next regular meeting? Okay.
As much as I enjoy the company of my fellow board members and staff sitting beside me, and I'd like to meet every day. We've already met, and I am putting together everything, the financial updates for 10 days apart. When we go to October, be fine.
I'm good with that. Anybody else object? You want to object?
No, but I do have a comment.
Sure, go ahead.
I don't know where Kaylee is with the orientation and the responses.
Right.
If that's already booked in members October.
It'll be the first 2 weeks of October.
Okay, because I was thinking since that is already booked in our calendars, we could have the orientation on that day.
Sounds like it's going to be October.
Okay, fine.
Yeah. Yeah, go ahead. So, go ahead.
No, nothing.
Nothing? Okay. Ellen Claire?
Yeah, yes, thank you. With regard to the orientation, I know there's been a lot of problems getting it happening. If it is indeed going to happen in October, that's great. Otherwise, I think we may be in breach of our policies to continue having board meetings if members haven't been trained. Dr. Ara, I'm fuzzy on the policy about it, but it seemed to me that it was early in the year, that the requirement was to be early in the year, and those that are not trained cannot participate or something like that. Is my memory serving me or no?
legal, Mr. Chair, correct, the orientation should be completed, then attestation should be given to the admin, and after that, the member can vote in open and or closed session. Otherwise, they cannot vote. That was the policy in 2021 when we did that. I was going to suggest, since everybody's around the table, or most of us, if we can find a date in October and provide this date to Kaylee. I know she has sent multiple emails without getting in. That's what I was going to say.
Yeah, no, that's fine. That's fine. And you know what? I appreciate your concern, Helen Claire, but, and I don't want to sound self-serving, but we're all busy. And it is always, as Kaylee, I'm sure can attest to, a challenge to get a date where everybody's available. So, I commend Kaylee and her efforts to, line that up, and, you know, we can only do what we can do. So, Helen Claire?
Yes, Mr. Chair, respectfully, absolutely everyone's busy. I just was riding on my colleague Sue's suggestion that since we have already carved out September, and so that we don't run awry of our policies and get into trouble because we're all sitting around the table, some have never had any training. And we're also not as efficient and nimble with our work around the board if we're not fully aware and engaged with what the responsibilities of our job is. So I was just going to support Ms. Patterson's suggestion that we keep this date, the 22nd, and that we come and take the training then. Thank you.
Okay, thank you. Kaylee, did you have something to add there?
The other option is, I've received a few responses that Friday, October 6th works either morning or afternoon. So I'm asking those that haven't responded yet, if they can look at their calendars to confirm if that works.
Okay. Well, why don't we leave it in Kaylee's hands and she'll try to get that lined up as soon as possible.
One further comment, Mr. Chair.
Yeah.
If we can't get that October date working, add it on to the October meeting. And everyone plan to be here an extra hour and a half or 2 hours, and let's do it. Get it
Fair
done.
enough. Fair enough. Okay. All right. Motion to adjourn. Sue Patterson or Sue Carlton? Second, Sue Patterson.
There you go.
Sue and Sue. That's easy. All in favor? Thanks very much. We stand adjourned.
Thanks, everyone. Have a great day.
Thank you.